Hemolytic anemia. Hemolytic anemias are caused by decreased RBC survival from increased destruction of the cells. The destruction may be inside the blood vessels, intravascular, or outside, extravascular, which generally means inside the spleen. Hemolytic anemia may be chronic, sickle cell disease, paroxysmal nocturnal hemoglobinuria, and hereditary spherocytosis, or acute, drug-induced hemolysis, autoimmune hemolysis, or glucose 6-phosphate dehydrogenase deficiency. Causes of anemia. Hereditary anemias: 1. Membrane, hereditary spherocytosis, hereditary elliptocytosis. Metabolism: G6PD deficiency, pyruvate kinase deficiency. Hemoglobin: genetic abnormalities, HbS, HbC, unstable. Acquired anemias: immune, autoimmune, warm antibody type, cold antibody type, alloimmune. Hemolytic transfusion reactions, hemolytic disease of the newborn, allografts, especially stem cell transplantation. Drug-associated red cell fragmentation syndromes. Infections: malaria, clostridia. Chemical and physical agents, drugs, industrial, domestic substances, burns. Secondary: liver and renal disease. Paroxysmal nocturnal hemoglobinuria. Clinical presentation. The usual symptoms of anemia are present based on the severity of the disease, not necessarily the etiology. Fatigue and weakness occur with mild disease. Dyspnea and later confusion occur with more severe disease. The major difference between hemolytic anemia and the micro and macrocytic anemias is that hemolysis is more often the etiology when the onset is sudden. Hemolysis is often associated with jaundice and dark urine as well. Fever, chills, chest pain, tachycardia, and backache may occur if the intravascular hemolysis is particularly rapid. Diagnosis: all forms of hemolysis can lead to sudden decrease in hematocrit, increased levels of LDH, indirect bilirubin, and reticulocytes, decreased haptoglobin level, slight increase in MCV because reticulocytes are larger than normal cells, hyperkalemia from cell breakdown, folate deficiency from increased cell production using it up. Folate stores are limited. Chronic hemolysis is associated with bilirubin gallstones. Treatment: transfusion is needed as in all forms of anemia when the hematocrit becomes low. Hydration is, in general, useful to help prevent toxicity to the kidney tubule from the free hemoglobin. Patients with chronic hemolytic anemia need to be maintained on chronic folic acid therapy, as there is an increase in cell turnover.